The third part of this video lecture is the last way to make a diagnosis. In order, is the outcome of a lab test consistent with a laboratory diagnosis of a particular disease? For this we use the Bayes theorem. The issue of most diagnostic tests is that the reference range, which is based on apparently healthy individuals, and the outcomes of diseased subjects do overlap. Actually, this implies that the outcome of the test can for the individual patient at best be described as the probability to be diseased or to belong to the healthy population. The Bayes theorem describes the probability of an event based on conditions that might be related to the event. In other words, it is a model developed to estimate the probability that an object or subject belongs to a certain group. It's named after Reverend Thomas Bayes, who lived in the early 18th century, who first showed how to use new evidence to update beliefs. It was further developed by Laplace, who first described the modern formulation of an axiomatic basis. In clinical chemistry, the Bayes theorem provides a method to calculate the probability of a disease after adding of new information, which is the test result, to previously obtained information, which in practice is the prevalence of disease. So it's the combination of the prevalence of disease together with the lab result that gives a probability of disease. In the next part, we will discuss the factors that are used to diagnostic accuracy or diagnostic quality management. We will explain the Bayes theorem with rule in and rule out of disease, and also parameters of diagnostic accuracy, which are sensitivity, specificity, positive predictive value, negative predictive value, the likelihood ratio of a positive test, and the likelihood ratio of a negative test. Because some of these are dependent on prevalence, we also discuss the definition of prevalence. We discussed the influence of prevalence on some of the factors, as said before. We talk about the information gain of a test. We will discuss the use of a receiver operator characteristics curve and the use of likelihood ratios. And we discuss the relationship between pre-test probability, likelihood ratio, and post-test probability. As you can see in this graph, there's always overlap between the distribution of the values from healthy subjects stated as controls and the diseased subjects. There's always a cutoff value that determines whether you're either in the control group, so you are considered healthy, or in the diseased group, so you are considered diseased. As you can see, most of the subjects are likely to be diagnosed in the right way, either true negatives or healthy and true positives or diseased. However, there's diseased subjects with a negative test outcome, and those are considered the false negatives, and subjects with a false positive lab result. In order, it's abnormal, but the subject is apparently healthy. So these are the false positives. Somewhere you have to set the cutoff value, and this means that there's always true negatives, true positives, but also false negatives and false positives. There's a special case in which you would like to rule out or to rule in disease. Ruling out disease means that if a test is negative, the subject is 100% healthy. This means that all the diseased subjects are not included. So the sensitivity is 100%, but there's a lot of people with false positive results. You can see the rule out level as the green arrow. The negative predictive value is 100%, and this means that all the subjects with a negative test are healthy. The subjects with a positive test are partly diseased, but you can also see there's many subjects that are apparently healthy that are first diagnosed as possibly ill. Rule out level means a normal test is the exclusion of disease. We can also apply the rule in level, in which only diseased subjects are included. This means that part of the diseased subjects are excluded and they are considered healthy, but at least we are certain that at a positive test only diseased subjects are included, and this means a positive predictive value of 100%. So there's 100% specificity, there are no false positives, and this means inclusion of disease. When do we apply rule out or rule in levels? The rule out level is applied when the disease is severe and treatable. It should therefore not be missed, and when false positives do little harm and the disease is identifiable with a second test. If you have a negative test, you are certainly to be healthy. The rule in level is applied when a disease is severe but cannot be treated. Absolute certainty is required to set the diagnosis, and when false positives have severe psychological consequences. The parameters that are used in diagnostic accuracy or diagnostic quality are sensitivity, specificity, the positive predictive value, and the negative predictive value. The sensitivity tells about detecting patients. It is the percentage of positive or abnormal test results in a patient population, and preferable and maximum is that 100%. The specificity deals with the detection of health. This means the percentage of negative test results in a healthy population. This means that this is the true negatives divided by the total population of healthy subjects, and those are the true negatives and the false positives. The sensitivity and specificity can be determined by knowing that subjects have a disease or not. In other words, the diagnosis is set, for example, with a gold standard or a different method. What you do is that you test the parameters of diagnostic accuracy, for example, of a new lab test, with use of the fact that a subject is diseased or healthy. So then you can calculate the sensitivity and specificity of the test. When a test is applied by, for example, a GP or an internal medicine doctor, he would like to know whether a positive test is indeed 100% chance of being diseased. So for this we use the positive predictive value, which is the percentage of patients in all subjects with a positive test result, which we would like to be 100%. In other words, it's the proportion of true positives divided by the true positives plus the false positives. If a test is negative, it may suggest healthiness. So the negative predictive value is the percentage of healthy subjects in all subjects with a negative test result, and this is preferable also 100%. It's calculated by dividing the number of true negatives by the total of negatives, which is the sum of true negatives and false negatives. Sensitivity can also be stated as the probability of a positive test in a population with the disease. This ratio is ideally 1 or 100%. The specificity is to determine health and can also be stated as the probability of a negative test in a healthy population, in other words, without the disease. This we also would like to be 100%. Again, the predictive value of a positive test is the probability of a disease at a positive test in a mixed population of both patients, true positives, and healthy subjects, false positives. And also this one we would like to be 100%. Predictive value of a negative test is the probability of health at a negative test in a mixed population of patients, false negatives, and healthy subjects, true negatives. Also, this should be 100%. Since prevalence influences both the predictive value of positive and negative test results, which we come back to later, it's important to tell about the prevalence and incidence, because they look the same but they aren't. The prevalence is the percentage of subjects in a population with a particular disease at a certain time. It can also be viewed upon as the probability of a particular disease in a certain population, or the probability of this disease in an individual. We call it the a priori chance. The incidence is the number of new patients with a certain disease in a defined time period, for example a year. It can also be viewed upon as the probability that an individual acquires the disease in a defined period. This slide shows the trend scenario of prevalence of disease from 2010 to 2030. We see an increasing prevalence of many chronic diseases, and it shows us that arthrosis is one of the major chronic diseases, followed by diabetes mellitus and coronary artery diseases. Another measure of diagnostic accuracy is the likelihood ratio. It is a measure of the likelihood of the diagnostic test result to indicate a certain disease. The likelihood ratio of a positive test indicates to what extent the disease has become more likely when the test is positive. It is also referred to as the demonstrating power of a positive test. It should be infinite. The likelihood ratio of a negative test indicates to what extent the disease has become less likely when the test is negative. It is also referred to as the denying power of a negative test, and should be 0. The likelihood ratio of a positive test means the probability that an individual with disease has a positive test divided by the probability that an individual without disease has a positive test. In other words, it's the sensitivity divided by 1 minus the specificity in order to create true positive divided by false positive. And this should maximum or infinite. The negative likelihood ratio is the probability which an individual with disease has a negative test divided by the probability that an individual without a disease has a negative test. It should be false negative divided by true negative. In other words, 1 minus the sensitivity divided by the specificity. And this should be 0. In other words, you would like to have the likelihood ratio of a positive test as high as possible and the negative likelihood ratio as low as possible. And this determines whether a test is okay or not. If we want to calculate the parameters of diagnostics accuracy, we make a kind of matrix. We start with patients who are diagnosed using another test or another technique, and healthy subjects. They are the columns of the table. Then we have subjects who have positive tests and subjects who have negative tests. The sensitivity can be calculated by dividing the number of true positives by the total number of diseased subjects, and this means the true positives plus the false negatives. So this means the percentage of positive tests in a group of patients. The specificity of a test is to detect the value of a test in the diagnosis of health. In other words, it deals about health, and most healthy subjects should have a negative test. So it's the true negatives divided by the total of number of subjects that are healthy, which is true negative and false positive. A doctor has a positive or a negative outcome of the test, and a doctor would like to know the chance of disease at the positive test, and this is called the positive predictive value, which is calculated by dividing the number of true positives by the total number of positives, which is true positive plus false positive. When a test is negative, a doctor would like to know whether the outcome is really negative, whether it's real health. And this means that we would like to calculate the number of true negatives as a proportion of the total negatives, and this means true negatives plus false negatives. The likelihood ratio of a positive test is calculated by dividing the sensitivity by 1 minus the specificity. In other words, true positive divided by false positives. The likelihood ratio of a negative test is 1 minus the sensitivity divided by the specificity. In other words, false negatives divided by true negatives. And we would like to have that at 0. The application of a diagnostic test should be useful, and this means that there should be an added value. We call it the information gain of a diagnostic test. Consider the fact that before the test application there's an a priori probability of disease, which is the prevalence of disease, and this is highly dependent on the population. Either is it the general population, is it a certain risk group, is it young subjects, is it elderly subjects, is it the population that comes to the GP, is it the selected population that comes to, for example, internal medicine outpatient clinic. There's many difference in prevalence of disease dependent on the population selection. Anyhow, we have a prevalence of disease, an a priori probability. We have a test result with a certain sensitivity and specificity, and the combination of them gives the posteriori probability, which is the positive predictive value of the test. The information gain of a positive test can thus be calculated by subtracting the prevalence from the positive predictive value. For a negative test, the information gain is the negative predictive value minus 1 minus the prevalence, because 1 minus the prevalence is the proportion of healthy subjects in the population. We will apply this in a screening protocol for cystic fibrosis. We use the data from a Dutch study to determine the optimal screening algorithm. Data of over 140,000 subjects, newborns, were used. They were screened using all of 4 tests. It's the IRT, it's the PAP, it's a DNA test for known mutation, and sequencing. All positive screening outcomes of all the 4 tests were confirmed with sweat chloride measurements to determine whether there was real CF. During the study, no infants were missed using the combination of all lab outcomes. No babies were referred to the pediatricians with symptoms of CF and were thus missed in the screening. They first calculated sensitivity, specificity, positive predictive value, negative predictive value with an IRT-PAP algorithm, which is shown in this slide. The outcome of this algorithm was that 2 infants had immediate symptoms of CF and were left out of the screening. The test was positive in 171 infants, of whom 21 had CF. The test was negative in 145,326 infants, of whom one had CF. When we apply the matrix or the table, we see a positive test in 171 infants. 21 of them had CF, and that means that of the 171 subjects, 150 were not diseased. 145,326 subjects had a negative test. One of them appeared to have CF, and many of them did not have the disease. What does it tell us about sensitivity and specificity? The sensitivity is the proportion of subjects that are diseased with a positive test. So we had 22 subjects with CF, 21 of them had a positive test, and this means a sensitivity of 0.95 or 95%. The specificity means how many healthy subjects have a negative test. Preferable, this is 100%. We see that the majority of them, 145,325, had a negative test and were not diseased. However, 150 of the healthy infants had a positive test without having CF, and this means a specificity of 99.9%, which is almost 100% but not entirely. If a newborn has a positive test, what is the probability to have CF? As you can see, we have 171 infants with a positive test, but only 21 of them have CF, and this means that the positive predictive value is 21 divided by 171, and this comes to 12.3%. We can also calculate the negative predictive value. In other words, what is the probability to be healthy when the test is negative? We saw that there's 145,326 newborns with a negative test. However, one of them had cystic fibrosis. When we calculate then the negative predictive value, it's 0.99999, which is 99.99%. Ideally, this is 100%, which holds also true for the positive predictive value. What about the information gain? The prevalence of CF is 1 in 6,613, which is very low. If we apply the prevalence and also 1 minus the prevalence, we can calculate the information gain. After applying the test, the positive predictive value, also, in other words, the chance to have the disease, was 12.3%. Before applying the test, it was 0.01%. This means that the information gain is 12.27%. Before applying the test, the chance to be healthy, or 1 minus the prevalence, was 99.98%. After applying the test, the predictive value of a negative test was 0.99999, which is 99.99999%. This means that the information gain is 0.01%. This is not an ideal screening algorithm because the combination of IRT and PAP has low positive predictive value. So another screening algorithm was tested. It combined IRT, PAP, DNA, analysis of known mutations and sequencing. It gave some other results. It was stated in the article that the test was positive in 24 infants. 21 of them have CF. The test was negative in 140,475 infants, and one of them had CF. If we apply this, we see that we find a test with the same sensitivity, 0.95%, 0.95, which is 95%. However, we see a higher specificity. There was less subjects that had no disease but had a positive test. The higher specificity increased the positive predictive value because after applying the test in the same population but a different algorithm, we found a positive predictive value of 87.5%. The negative predictive value was slightly lower, but not really. From these results, we can conclude that in screening a higher specificity increases the positive predictive value without having a significant influence on the negative predictive value. Not only specificity is influencing the positive predictive value, also the prevalence of the disease. This slide shows us the influence of the prevalence on the positive predictive value. Not only specificity is important, but also the prevalence of the disease. This is shown by applying the IRT, PAP, DNA sequencing strategy with a sensitivity of 0.95 and a specificity of 0.99999 in two populations. The first population is a population with a prevalence of 1 in 10, in order 10%, and the second population is a prevalence of 1 out of 100,000. We apply the same tests with the same sensitivity and the same specificity, but we have a very different predictive value. If we apply a prevalence of 1 in 10, means that we have 1,000 subjects, 100 of them have the disease, 900 of them do not have the disease. With a sensitivity of 0.95, 95% of the diseased subjects have a positive test. 5% of the subjects have a negative test, but are diseased. With a very high specificity and many subjects without the disease, we will find 900 subjects rounded with a negative test that are healthy, and also a very small amount of subjects that have no disease but have a positive test. This means that almost any subject with a positive test has the disease, and this is shown in the positive predictive value, which is 1, resembling 100%. The information gain of this test for a positive value is 89.918%, in other words 90%. The negative predictive value is 9.45%, because after the test we had 99.45% chance of having the disease, we had 99.4475% chance of being healthy, and before applying the test it was 90%, so the information gain is 9.45%. When we apply the same test with a population with a prevalence of 1 out of 100,000, we see that we have one subject with CF. It is statistically it is diagnosed. There's a small proportion of subjects with the disease that are not diagnosed. However, there's 99,999 subjects without the disease. When we apply a specificity of 0.9998, this means that the majority of the subjects have a negative test, but we find 2 subjects with a positive test. This means that we have a total of about 3 subjects with a positive test, but only one of them has the disease. And this means that the positive predictive value is about 32%. Before applying the test, there was a very small prevalence, in other words, a very small probability of disease, and after applying the test, it was 32%. This means that the information gain is about 32%. For a negative test, application of the test has very little use because the information gain is 0.0009%. In other words, we have to have very good reasons to apply a test in a population with a low prevalence, because the information gain is low and the positive predictive value is very low. It is better to have a certain prevalence in order to apply a test. However, we still apply tests for screening that are not perfect. We saw that the screening strategy for CF had not a sensitivity and specificity of 100%. However, screening is a special diagnostic tool. It identifies preclinical disease stages or identifies risk factors associated with disease. And it's only performed when early detection improves prognosis. This means that we consider the higher number of false positives when we apply screening. But we also know that we need a second test to confirm the diagnosis. In other words, to exclude all those ones with false positive results. It means that the criteria for screening are diverse. There should be a presence of a detectable preclinical disease stage. It should be more effective or otherwise attractive treatment or prevention in the preclinical stage as compared with the clinical stage. And then we consider costs. It should be less hazardous or technically easier. There should be a certain frequency or prevalence of the disease, because we know that a low prevalence gives a high false positive ratio. There should also be a certain severity of disease and consequences, and this considers both mortality and morbidity of the disease. The effectiveness and safety of treatment should be determined. This means that the treatment should be available and acceptable by those who are found positive. Also, there should be a high accuracy and precision of the screen test, because we have seen that a low specificity gives rise to high percentage of false positives, especially on low prevalences. On the other hand, a low sensitivity gives rise to high percentages of false negatives. The screening test should be safe, and there should be no disadvantages or little disadvantages, and it should be cost effective. Nowadays, all newborns are screened for 15 diseases, in addition to the ones that were already screened for 4 ages, which are phenylketonuria, adrenal congenital syndrome and congenital hypothyroidism. And cystic fibrosis is one of them. We stress the importance of the relatively many false positives, in other words, low prevalence, and this is very well depicted in this graph, in which we show that at a low prevalence there's relatively many false positive subjects. We have seen that sensitivity and specificity have opposite relationships. If the sensitivity goes up, specificity goes down, and the other way around. This means that we have to find the optimum between sensitivity and specificity, and this can be done using receiver-operator characteristic curves and likelihood ratios. The ROC curve was first developed by electrical engineers and radar engineers during World War II. They detected enemy objects in battlefields, and it was soon introduced in psychology to account for perceptual detection of stimuli. Our ROC analysis since then has been used in medicine, radiology and biometrics. In World War II, the operator at the radar detection of enemy objects had to decide which signals were alarming. False alarm should be avoided without missing a real signal. In other words, false positives should be avoided, but true positives should be detected. For this, the operator had to choose between false alarm and no missiles, or no alarm and many missed missiles. And actually the same holds true for diagnosing a disease. There should be no false alarm, but we should also not miss the disease. The ROC curve shows the relationship between diagnostic specificity on the x-axis and sensitivity at various cutoff points. We see that at different cutoff values that the proportion of subjects without the disease and with the disease changes, but also the sensitivity and the specificity of a test. So a ROC curve tells us the specificity depicted as 1 minus the specificity and the sensitivity. We depict the specificity as 1 minus the specificity in order to be able to pick the best balance between sensitivity and specificity, because we all want them to be 1. And this means that the optimal sensitivity and specificity is over here, a sensitivity of 1 and a specificity of 1. And this means 1 minus specificity is 0. We see that also the area under the curve is very important. When it's 50%, we'd better take a coin and throw the coin. In other words, we have 50% chance to have a good result. This means 50% sensitivity and 50% specificity. As stated, we would like to be the sensitivity and the specificity both 100%, but as stated before, this is not possible in true life. We pick the point that is most close to this upper corner, which means the best relationship between sensitivity and specificity. So in this graph, it should be this sensitivity and specificity that we choose for our test. We prefer an area under the curve of 100%. We don't like an area under the curve of 50%. And if we would like to compare tests, we take the test with the highest area under the curve, which is in this case this test instead of this test. This is also shown in this graph, in which we show the effect of random guessing, the worst test, a better test, a yet better test, and the best test, with the highest area under the curve and a sensitivity and specificity close to 1. We apply the concept of our ROC curve use in the parameters that are used for Christine Franzen. Christine had a high risk of infection of the lungs. For this, we can measure CRP, the temperature, because subjects with infection have fever, and also the white blood cell count. As you can see in pneumonia, there is increased CRP, there is increased temperature, but there's also overlap between the values of non-infected and infected subjects. In other words, no sensitivity, neither specificity of 100%. This means that a certain cutoff value has to be found, and this can be done using an ROC curve. This slide shows the ROC curve of C-reactive protein on the solid line, the temperature, the dashed line, and the white cell count, the dotted line, in the diagnosis of infection. We see that use of the white cell count is not a very good measure of infection. The use of temperature is slightly better, but the best is the use of the CRP. This shows us that an ROC curve can be used to find the best test to detect a disease. We showed here that the ROC curve of white cell count shows a poor diagnostic performance and that CRP are more reliable than temperature. Their area under the curve for CRP was 0.92 and that for temperature was 0.78. This means that CRP has a higher diagnostic accuracy. The last parameter of the diagnostic accuracy is the likelihood ratio. It is a measure of the likelihood of the diagnostic test result to indicate a certain disease. The likelihood ratio of a positive test indicates to what extent the disease has become more likely when the test is positive. It is also referred to as the demonstrating power of a positive test. It should be infinite. The likelihood ratio of a negative test indicates to what extent the disease has become less likely when the test is negative. It is also referred to as the denying power of a negative test and should be 0. The likelihood ratio plays a central role in evidence-based laboratory medicine, and it indicates the quality of the test for target diagnosis. As stated before, the likelihood ratio of a positive test is the sensitivity divided by 1 minus the specificity, in other words, true positives divided by false positives, whereas the likelihood ratio of a negative test is the probability of a disease divided by the probability of health at a negative test. This means false negative divided by true negatives, and this should be 0. It can be calculated by 1 minus the sensitivity divided by specificity. The advantage of the likelihood ratio is that it is independent of prevalence, in other words the pretest probability. And when it's combined with prevalence, it determines the post-term test probability. How do we interpret a likelihood ratio of a positive test? A high likelihood ratio of a positive test is okay. A likelihood ratio of over 10 means a large and often conclusive increase in the likelihood of disease. A very low likelihood ratio, below 0.1, means large and often conclusive decrease in the likelihood of disease. When we apply the screening of CF using the IRT-PAP DNA sequencing strategy, we find the likelihood ratio of a positive test to be 40,287. In other words, a very high likelihood ratio of a positive test. The likelihood ratio of a negative test is 0.005, which means 0.05. The likelihood ratio of a negative test is calculated by 1 minus the sensitivity divided by the specificity is 0.05, which is very low. This means that the algorithm that is used is good for the detection of cystic fibrosis. Here we see the diagnostic value of blood tests in subjects that are treated with antibiotic for suspected pneumonia in a general practice. And also we see that the likelihood ratio can be calculated from the sensitivity and the specificity, and this is high for the CRP. So this tells us that the use of CRP in the detection of pneumonia is good. To test or not to test is dependent on the pretest probability and the likelihood ratio of an available test. We discussed before that at a low prevalence the positive predictive value is low. Also, the likelihood ratio tells us something about the probability of disease after performing the test. In general, and this depends really on the severity of disease and the treatability, below a prevalence of 0.25, it's better not to test and maybe not to treat. Above a prevalence of 0.65, do not test but get on with treatment. Between 0.25 and 0.65 of prevalence, the test and treat should be on the basis on the test result. As stated before, the pretest probability plus application of the likelihood ratio gives us the post-test probability, in other words the positive predictive value. As can be appreciated, the positive predictive value increases with increasing likelihood ratio and prevalence. The combination of tests may increase the efficiency of testing because the likelihood ratios are multiplied.